Assalamu alaikum, the short clinical station day. First scenario, you are going to examine the chest for Mrs. Patel, presented with breathlessness.
Okay, I will enter to the room.
Perfect.
Then I wash my hand and I will go to the wall and read the instruction, examine the chest. I go to the patient and I tell him, hello, I'm Dr. Huda, one of the doctor in the clinic today. Are you Miss female or male, Dr.
Mrs.
Bassem?
Patel, yes, that's me.
Oh, okay. Are you Miss Sarah?
Yes, that's me, doctor.
Okay. Today I want to examine you. Okay. I will touch your chest and I will listening to your chest. If there is any pain, you can inform me. It's okay with you?
Yes, doctor.
Okay. Then I will go back 2 steps back. I will go to the end of the bed and I will see around the patient if there is any oxygen cylinder or any bottle for the sputum.
Oxygen cylinder with nasopharynx.
What?
Oxygen cylinder. There's oxygen cylinder.
Okay. Then the patient, he must in the 45 degree. Okay. Then I will stand in the end of the bed and I ask the patient to take breath. And
Okay.
I will check if there is asymmetry movement of the chest.
Symmetrical movement of the chest.
Okay. And I ask him to cough.
Okay.
Any sputum or anything?
Yeah, wet cough.
Why?
Wet cough.
Wet cough. Okay. Then I will go beside the patient on the right side. I will remove the clothes and I will start by inspection of this chest. If there is any scar or any scar or any abnormality in the deformity of the chest.
There is a scar. Okay.
Where exactly?
On the lower part of just below the subclavicular area on the right.
Subclavicle
Clavicular, yep.
area and
on the right.
Okay, in the right side. Okay.
Mm.
There is any another scar or anything?
No, that's just a scar.
Okay. After that, I will start to do percussion for the patient.
Mm.
I will start from in front, then I will go to the back.
Okay.
Up, I will start by the upper area above the clavicle. Then I will go down. Anything? Crepitation? Sorry, any dullness?
On the no dullness.
No dullness. Okay. I will go to back and I will do also the percussion, also from upper down. Any dullness?
No dullness.
Okay. I ask the patient to say no dullness. Okay.
No dullness.
I ask the patient to do to say 99.
Okay. 99. 99.
Tactile frame test.
99, 99, 99, 99.
Degrees increase.
Is normal.
Normal. Okay. Then I will start by auscultation. I also start from in front, then to the back. Any crepitation or any wheezing?
Inspirational crepitation, no wheeze.
Sorry, what?
Inspirational crepitation, no wheeze.
Respiratory?
Is that what?
You said inspiratory crepitation noise?
Yes, there's crepitation. There's a
All over?
crepitation. Yeah, all over.
Okay, I ask the patient to cough. I want to see, listen, if it changed after cough or no.
It changes with cough.
It changed with cough. Okay, then I will examine the chest, cardiac.
1 minute
First,
left.
second, okay, first, second heart sound, and second heart sound, B2.
Loud
It's
P2.
high or anything?
Loud
What?
P2. Loud P2.
Okay, and I want to check the GVB raised.
Not raised.
I will check also lower limb if there is edema.
No edema.
Okay, finish the examination.
Okay.
You want to
Thank you.
examine from the front, the same steps?
Yes, by auscultation same in front and
Okay.
back.
Okay. What? Only one element left. You have to examine.
Trachea. I must examine trachea if it's shifted or no.
Okay.
Uh,
And the last?
Auscultation.
Remember, all the lymph node is missed by every candidate. Lymph node. Okay.
Okay. Supraclavicle. Okay.
Cervical and cervicolavicular. Yes. Okay. Time is up. The examiner questions.
Well, so summarize your patient, doctor.
This female patient came complain shortness of breathing. By examination, by inspection, there is a right subclavical scar, and by inspection, normal chest movement. There is wet sputum, and by examination, inspection scar, and in the percussion, it's normal, no dullness, and by auscultation, there is inspiratory crepitation, it change after cough. Trachea, I don't know, centralized, because I'm not examined, centralized or shifted.
Okay. So
There is a loud B2, no lower limb edema, and no raised GVB.
okay. So what's your diagnosis?
Most probably this is chronic obstructive lung disease.
Okay. And what are your differentials?
Because she has crepitation all over the chest. Maybe she has bronchiectasis. Maybe pneumonia, infection. You want differential diagnosis for COPD or for?
From your clinical findings, what other things do you think can be?
Pulmonary edema, bronchiectasis, and COPD.
Okay. So, what do you think the scar, the supraclavicular scar, infraclavicular scar, could have been used for?
Maybe this is for lobectomy.
Okay. So what are the indications for lobectomy? In COPD?
For COPD, for decrease the volume, and if there is boli, yes.
Okay. So what are the contraindications to a lobectomy?
Forced expiratory volume in 1 minute less than 1 liter.
All right. Okay, so let's say this this patient has bronchiectasis. What are the possible things? What are the possible causes of bronchiectasis?
Bronchiectasis, there is many cause. Recurrent infection, cystic fibrosis, Cartigener syndrome.
Okay, so tell me the pathophysiology of cystic fibrosis.
In the cystic fibrosis, there is increase the chloride in the cell. For that, all the secretion very thick, and we can the patient cannot flush it.
Okay, so how is cystic fibrosis the inheritance of cystic fibrosis, the genetics of cystic fibrosis?
It's genetic. It's genetic.
Yes, how is it inherited?
What?
What's the mode of inheritance?
Autosomal recessive.
Okay. Okay, so what are the other organs that can be affected in cystic fibrosis?
It can affect pancreas, pancreas, it's also affected, it's caused infertility. Cystic fibrosis.
Okay. How will you treat cystic fibrosis?
What?
Treatment of cystic fibrosis.
This patient, he needs a multidisciplinary team, education, counseling, physiotherapy, special nurse, occupational also. He need we need educated the patient about clear the chest, how he's clear the chest from the secretion. He need the inhaler and the regular antibiotic, also inhaler and tablet.
All right, thank you, doctor.
Thank you, doctor.
Perfect.
Well done.
Yeah, perfect, Dr. Huda. Although you are stressed, I can feel that, but you answer all the questions and the performance was good. Let's hear Dr. Ayula comment, then I will comment.
Okay, thank you for the presentation. I know it was an impromptu one. You were not prepared to present today, but still you did well. Okay. The way you started was good. The hand sanitizer thing, observing from the foot of the bed, asking the patient to cough, and looking around for the form of oxygen cylinder or sputum port was good. And but the step, I think maybe because you were not really prepared for the station, so to say. I think some of the steps of respiratory examination were missed. First, the hand of this patient was not examined. They examined the hand of this patient. If you have examined, I would have told you about finger clubbing that he has. Okay, I thought the person was saying something. Okay, the finger clubbing that he has, and the general habitus of this patient will have been, okay, let's start from general habitus of this patient will have been small will have been quiet, will have been small, and then finger clubbing. Then, clogging of the hands might be important in this patient, because see finger clubbing, you want to see if there's any form of respiratory failure, and flapping can point to the fact that the patient might be having some CO2 retention. So you also want to check for finger flapping in this patient as well. Okay. You also want to check for the pulse rate, because it might be bounding, which will also point you towards CO2 retention in this patient as well. It's quite important for I'm just mentioning those steps that you could have checked and would have given if some clue before we go to the chest. Then pallor for someone that is breathless. You just want to check any form of anemia. Then cyanosis in the mouth. You also want to check for cyanosis. Then JVP. I think you check for JVP. Then lymph node examination that has been pointed out during the examination proper. So lymph node examination, and then when you were discussing when you were talking about the examination, you were saying, okay, I will check dullness in the front and the back. I think it's just. I think that's it's I think checking for the front first, complete the front, I mean, and then you go to the back will be a bit more systematic than, okay, I'll check for the back. Because in the real examination, you can't say, okay, you can't check for dullness in the front, go to the back, check for dullness, okay, patient lie down again, check for that fermenters, okay, stand up at the back again. So just do the front one, then complete the back side of the examination, and then in that manner. Then the pedal edema that was checked, the cardiovascular examination was quite good. And then the evidence of fluid retention that you checked by the pedal edema was also good. But the scar, I don't know if you see the scar I sent on the page. Excuse me. I sent in the scar on the page. I know I didn't mention that. The scar on the page. I think I did.
Yeah,
Yes.
yeah. I shared it here in the chat box.
Okay, so this car would have been something that what do you say this car would have been for lobectomy? Okay, and that was why I said that what are the indication for lobectomy but for this car, I think with the whole examination findings of you picking the bronchiectasis, features of bronchiectasis, the inflational crackles that changes with cough, and there was no wheeze, no ronchi, no wheeze. But you place COPD ahead of bronchiectasis in this young lady. So I was just thinking, okay, well, it could be a possible differential, but there was no ronchi, no wheeze. So bronchiectasis possibly have come ahead of COPD in this patient, and this scar could have been something like a podcast scar, previous podcast scar that have been used for delivery of antibiotics in a patient with cystic fibrosis. This is another possibility. It could be a lobectomy scar, possibly the upper lobe part of it, but for that bronchiectasis and possibly thinking about previous scar, podcast scar in cystic fibrosis, causing being the pathology of the bronchiectasis, basically. And of course, you did discuss the bronchiectasis well. We talked more about the pathophysiology, which is good secretion of thick mucus because of deficiency in the chloride in the chlorine channel. Okay, so the mucus is not well. There's not enough. What do you call it? It's thickened, causing the blockage of those bronchial, and then patients start having evidence recurrent cough, and also dilatation of the airway because of the obstruction that this sputum, the mucus, is causing. Other organs that it can affect, of course, the lungs, the bronchioles, the pancreas, the gut, and also the fallopian tube in female and seminal duct in males. These are the organs that other organs that it can affect it. So altogether, the presentation was good. You did quite well for an impromptu presentation. It was a good one. Well done. Thank you.
Thank you, Dr. Ayul.
Yeah. Thank you, Dr. Ayola. Good preparation and performance about the presentation and the possible questions. Then let's comment from the start, as Dr. Hoda did everything and she missed the most important, not the most, but one of the most important thing. The examiner might ask, what are the peripheral signs in this scenario or in this patient? You missed the hand totally. In a way, you weren't ready to start the station or to do this station. You were volunteered to do it, and you were brave to start and to do this as the first time without even preparation. I believe you did great. The presentation, the questions, the examination. Again, apart from the hand examination, you miss only the peripheral sign. Here in this scenario, clubbing could be positive. The flapping tremors could be also positive. Cyanosis, peripheral cyanosis could be there. And the pulse, you have to check for the pulse quickly. Jaundice, sorry, not jaundice, any pallor in the hand, or any injection mark, maybe catheter, maybe venous catheter or cannula for antibiotics. But back to the scar in the chest, it's could be, as Dr. Ayula mentioned, the portacat for antibiotics, or even sometimes they are giving such patient replacement. Okay, with cystic fibrosis particularly. Lobectomy, it's possibly for the right upper, but most of the time it would be lateral thoracotomy scar. Okay, the both possible finding as well could be gastric tube, or sorry, big tube. For sometime they are giving this such patient replacement or formula to replace the pancreatic enzymes. For the other examination steps, I am against Dr. Ayula to start examination from the back. Why, Dr. Ayula? Because most of the time, the steps of examination takes time. Whenever you start from the front, sometimes you cannot make finding compared to the back. The back always, you can hear the crackles clearly. From the front, sometimes the cardiac shadow, the area of auscultation is not exposed compared to the back. So whenever you hear it from the back, you can pick up the crackles, as in respiratory crackles, particularly the bibasal ones. But if you start from the front, sometimes the steps consume the times and you don't have the time to do the back examination and you might miss the case. Okay? So you will start the back examination, inspection, palpation, percussion, auscultation, of course, after doing trachea. Let's start as the steps from the beginning. Standing at the end of the bed, any surrounding, asking the patient to cough, symmetry, asymmetry, then the hand examination, going up to the face, the eye examination, the mouth, cyanosis or no, the tongue itself, sometimes the lung transplant, you can ask for gingival or gum hypertrophy signs, then the trachea. While you are examining the face, now the time to examine the trachea. So the trachea you can examine after examining the face. Is it transcentralized or no? You want to do the cardiac examination now? You can do it for pulmonary hypertension or the apex itself, or the signs, as I said, the signs of pulmonary hypertension or the apex. I will ask Dr. Huda now why it's important to examine the apex in this scenario, particularly. Dr. Huda.
Yes, doctor.
Why you can or you have to examine the apex in this scenario?
Apex.
Yes.
Sometimes there is Bankus tumor, but I think not in this case.
No, I'm not. No, it's not Bankus tumor. Apex, either in place or displaced or malposition. Right? You got it. Any PACE's case, the apex, either to examine it, is it in place and the character of the apex? This is in the cardiac station. Or displaced, again, in the cardiac station for any mitral or the aortic regurg. Or,
As
yeah, or maybe malposition or in the left side. Sorry, the right apex, right side apex. What do you think if you find apex beats at the right side? What could be the case related to our case today?
Cartignal syndrome.
Perfect. Yeah, Cartagena syndrome would be the same presentation, bronchiectasis associated with dextrocardia. So you have, in this scenario particularly, you have to examine the apex, plus the pulmonary hypertension, loud B2 or barsternal heave. That's enough. Next, move to the back, examine inspection, palpation, percussion, auscultation. Don't forget to expose all the back. Okay? Don't leave. If there is, for example, a female and she's shy, you can either to ask for the welfare, ask the examiner, shall I remove? But don't ever auscultate above the clothes, whenever or whatever is there. Do not auscultate. Either to put the stethoscope under or to ask the patient to remove it if it is okay. Okay, the rule for the male are the same. So any patient with any gown, with any clothes, you have to remove it after asking the permission. Okay, so the steps already done: inspection, palpation, percussion, auscultation. In this scenario, of course, you will have the inspiratory crackles, coarse crackles, which can be cleaned or disappear after coughing. Otherwise, the expansion could be okay, the percussion could be okay, unless if the patient is surgical emphysema, so not surgical emphysema, sorry, alpha 1 antitrypsin, and he has emphysema associated, or COPD with hyperinflated lung. So you might have hyperresonant chest, but not in this scenario. That's why the age of the patient is important, Dr. Huda. While you have patients in early age, what the first differential you can say?
Early age,
Yeah,
young,
patient, yes.
uh, genetic like cystic fibrosis or
Exactly. So you will go more on the top of your differential, cystic fibrosis or Cartagnar or any syndrome related to the bronchiectasis. If you have in the other arm, if you have elderly patient with bronchiectasis, what could you say or what could you give as a differential on the top?
a chronic infection.
Yeah, the chronic infection or COPD sometimes complicated with bronchiectasis, right? Cancer, okay? These are the possible differential according to the age. So whenever you have early patient or a young patient, so you give different differential than the elderly patient. That's why while you are presenting the patient, you can say, I examine this young lady, young gentleman, or elderly lady or elderly gentleman, looks comfortable, looks dysnic. He has oxygen cylinder around, and by this way. So start by the surrounding. Of course, if the patient comfortable, not or not, any surrounding around, and the physical appearance, cachectic or underweight or whatever. Then you can start presenting the finding according to the peripheral or central. I prefer to say in this way, peripheral signs, I could find or I could appreciate peripheral signs such as, and enumerate them, one, two, three, or central finding like cyanosis, central cyanosis, trachea, by inspection, by percussion, by auscultation, and all these features together suggestive that I have patient possibly might be as bronchiectasis because of according to the age. If there is a young patient, so I can say this is a patient presented with bronchiectasis, possibly due to cystic fibrosis. I have to do further workup, genetic testing to confirm the diagnosis. He will ask you what the differential. Now the time to get a differential, you can say Cartignan or I think mumps, right? Infection, or also foreign body. It can lead to, right? But you cannot say COPD in young patient. COPD in the elderly patient as a differential, it would be in the top. Okay. So yes, I would like to take history to confirm if this patient is having younger infection or a childhood infections, and accordingly, I can put
ما عارفة
my differential. Okay.
بدي غيرت المخدة دي، المخدة دي
Sorry,
بتوجع علي
I
راسي
will
ما
mute
أخذت.
someone.
بعدين حسيت إني ما أخذت.
Okay. Any question? The vaccination is very important, Dr. Huda, whenever you have COPD patient or bronchiectasis patient. Sputum culture as specific investigation, don't forget it. If you want to specify investigation for cystic fibrosis, you have to mention a sweat chloride test. It would be more than 60. Okay? Genetic testing, definitely one of the confirmatory tests in this scenario. The complication, don't forget to mention the diabetes as a screening. Okay? Pancreatic enzymes as well. And you can also check for immunoglobulin for recurrent infection. If you have recurrent chest infection, you can offer antibiotics for long term based on the culture. There is also a question about transplant. What do you think the contraindication for transplant in such patient, Dr. Huda?
Bronchiectasis.
Yeah. Is it
So
possible
in the
to be
bronchiectasis,
transplanted? Yeah. Cystic fibrosis, particularly.
I think they transplant lung with liver, I think. صح ولا لا؟
Pancreas, you mean pancreas?
Pancreas, yes.
No, my question is, what are the contraindication to transplant such patient? I will specify the question more. What culture from the sputum it would be contraindication for transplant?
Culture.
Yes, this is the answer. Porphyria as an organism, it's contraindication for transplant. Okay.
Okay.
There is other contraindication, by the way, general, as we mentioned in the last session, for the abdominal station. So you might say, if the patient is undergoing infection, acute infection or ongoing infection, cancer, even you can say surgery contraindication and anesthesia contraindication, obesity, or a patient with comorbidity. Okay, all these are possible contraindication. However, a specific contraindication as a lung culture, as we said, orchidaria, one of the contraindication, if the positive culture showing this organism. Okay. Any question, Dr. Huda? Dr. Ayola,
Mm.
any missed point? Anyone with question? Any doubt about this scenario? Okay, Dr. Ayola, I will ask you, is it possible to be the scar for the supraclavicular? Can we mention the pacemaker? I know it's not the case, but it's the area of the pacemaker insertion as well.
Yeah, possibly. Am I muted? Yes, possibly. But then because it's the chest
Yeah, the
space.
case is chest, but it's common scar for pacemaker. So you can mention it could be for any associated cardiac problem. This patient
Okay.
might have AV block, and he had occasionally pacemaker insertion, for example. Okay.
Yeah.
Any other point you want to raise apart from you mention and me?
Yeah.
Dr. Huda, any question?
No, thank you, doctor.
Okay, any question from others? Let's review the chat box. Dr. Huda, you prepare a case? Okay, I will try to read the comments quickly. Chest expansion, Dr. Omar, Muhammad Omar. Yeah, it should be done. Again, start these steps from the back. If you have the time to examine the chest from the front, do them. If no, at least you pick up the finding. Possibly, but don't miss the cardiac examination from the front. So I prefer to start with the face, then trachea, then cardiac, then ask the patient to sit and examine the back. If you have the time to examine the chest from the front, do it after finishing the back. The legs, of course, at the end or earlier while you are standing at the end of the bed. I prefer to do it while standing at the end of the bed. You already had step backward to check for a surrounding, to check for the expansion of the chest grossly. The same time, examine the legs for edema. I prefer to do so because whenever you start the chest examination steps, after finishing the back and the front and the lymph node, either you don't have the time or you will be missing the legs. Don't forget to examine, to thank the patient and to cover him at the end. Always. And of course, wash your hand. Okay. Other questions? Cartagnar, maybe dextrocardia. Exactly, Dr. Muhammad Azam. Chest, childhood infection, of course. Yellow nail syndrome. You will have yellow syndrome. You will have yellow nail. Okay. You mean as a differential? Okay, but if you want to say as a top differential, it wouldn't be. So you can put it as differential. Differential diagnosis in the scar of this patient, as we mentioned, portacath for antibiotics, or the other thing was bulectomy or lobectomy, upper lobe, or pacemaker occasionally. But you cannot say, for example, a pneumonectomy or transplant. You cannot say it at all because it's very small scar. Okay. Whooping cough, yes, I agree, Dr. Muhammad, thank you. Whooping cough and bumps. I remember also mumps can be as a cause of bronchiectasis. Scar, I guess lung biopsy, okay, VATS, chest tube, lung reduction surgery. Let's talk about VATS and chest tube or pleural. It wouldn't be from the apical or from the front. Usually they do it from the lateral side, from the chest wall side. So the only thing can do here, either related to the cardiovascular, portacat, major vessels, or pacemaker. Even lobectomy, I don't think they do it from here, but it could be as a upper right or right upper lobectomy only. But other lobes could be accessed by the lateral side of the chest. By the way, VATS, as a scar, you will have three scars or three small scars and one major 3 or 4 centimeter scar. So for every port, you will have a scar, but the major vessel or sorry, the major scar would be 3 centimeter for the instrument. But usually, three small scars is associated. Borchidaria we mentioned already as a contraindication for transplant. Dr. Ayula, your case is ready. 65 years. Gentleman present with short of breath and cough, dry cough. Ready?
Yes, please.
Okay, here you go.
So I entered the room. Hello,
Yes.
my name is Dr. Ayola, and thank you for allowing me to examine you today.
Okay.
Can I confirm you are Mrs. Sarah, 65-year-old, Mr. Sarah, Mr. John, 65-year-old?
Yes.
All right. Thank you for allowing me to examine today. So I put my hand sanitizer and I go to the edge of the bed. I look at the surroundings for any cylinder, oxygen cylinder, nebulizer, inhalers, hospital oxygen port.
No,
Okay.
no.
Okay. Thank you. Can you breathe in and out, please, Mr. John?
What?
Breathe in and out.
Okay.
All right. Thank you. And can you give me a big cough? All right.
Dry cough.
Dry cough. All right. Thank you. So I move close to the patient. Can I examine your hand, please? So I look
Yes.
at the hand. I'm looking for evidence of any finger clubbing.
No clubbing.
Okay. Any nodules in the hand? And
What?
any nodules or rash in the hand?
No.
Okay. So I move forward to check for the pulse. How's the pulse like? Is it bounding?
But wait, sorry, doctora, but in the hand there is some deformity.
Okay, some deformity in the hand. Okay, all right. Thank you. What sort of deformity? Is it joint deformity? Is it what sort of deformity exactly?
Joint deformity.
Joint deformity. Okay, so I come to the pulse. How's the pulse like?
What?
Pulse. I'm examining the pulse.
Yeah, both. Okay.
The pulse. Is it the pulse?
Pulse.
Yeah.
Okay, all right. So,
No. Yes, normal pulse.
okay, normal pulse. All right. So I go up. Can you face the other side for me? So I'm checking for the JVP. Is it raised?
No.
All right. Have you got any pain in your tummy, Mr. John?
What?
Any pain in the tummy?
No.
Okay, so I did hepatojugular reflex. All right. And then,
Yes.
okay, can you pull your eyelids down for me? I'm checking for pallor.
No.
All right, so I pick my pen touch. Can you open your mouth for me, please? I look inside the mouth for cyanosis.
No cyanosis.
All right, thank you. So can you sit up for me, please? So I'm checking for lymph node enlargement. Can you stroke
No.
your shoulders for me? Okay, I'm
No.
stroking the shoulders. All right, thank you. So you can lie down. Thank you. So I'm going to raise up the can you remove your shirt for me? So I'm
Yes.
looking. Okay, so I'm looking at the chest. Any scar?
No.
No scar.
No.
All right. So I'm going to examine your windpipe now. Bear with me. It might be a little bit discomforting. So I'm checking for this tracheal centrality. Is it tracheal central?
Yes.
All right. Thank you. All right. So I'm going to put a hand in your chest. I want you to breathe in and out for me. Okay. So can you breathe in and out?
Okay.
I'm checking for the expansion in all the three segments.
Okay. It's degrees in the lower zone.
Decrease in the lower zone. All right, thank you. So I'm just going to tap your chest now. So bear with me, okay? So I'm checking for percussion notes in all the three lobes. Percussion notes.
Percussion, there is dullness in the lower zone also.
Dullness in the lower zone. All right, thank you. So when I put my hand on your chest and you say 99 for me, okay? So say
Yes.
99.
Yeah,
Okay.
99. Yes.
Okay. All right. Tata fremitos. Anything in the tata fremitos?
Yes. Increase.
Increase. Okay. So I listen
Yes.
to the chest. I
Yes.
put my stethoscope in your chest and then you say 99 for me. Is that all right?
Yes.
Okay, so I listen. Anything in the chest? Focal fremitos.
99 degrees.
Okay, so can you breathe and out for me, please? Give me a nice deep in and out, okay? On all the
Yes.
segments in the lungs, okay? All right.
Yes.
As a breath sound.
Breath sound, there is a physical breathing with the prolonged expiration.
Oh, long what?
There is
Long.
breath sound is physical with prolonged expiration.
Okay.
And
Any crackles?
in respiratory crackles in the base of the lung.
All right. Thank you. Can you give me a cough, please? Does it change with cough?
Not yes, hiccup, but not a change with cough.
Not a change with cough. All right, thank you.
Yes.
So can you sit up for me? So I'm going to do the same examination at the back. So I'm checking for expansion. I'll check
Yes.
for dullness, percussion notes.
Yes.
Okay.
Percussion, as I told before.
All right. Okay. And then I'll listen to the chest. I'll listen to the chest. Is it the same?
Same in the lower zone.
All right. Thank you. So I'm going to examine the heart now. Can you lie down for me again, please? Thank you. So the apex
Yes.
beats.
In the fifth intercostal, not displacement.
Not this. And is there any right? Is there any left parasternal heave?
What?
Left parasternal heave.
No.
Okay. Then I listen to the heart sound.
Normal.
Okay. Any
Second
pitch?
heart sound normal.
All right. Thank you. So I go to the leg. Mr. John, do you have any pain in your legs?
No.
Okay. So I'm going to check for pedal edema.
No pedal edema.
No pedal edema. Okay.
Okay.
Thank you.
Yeah,
You can cover yourself, please. Thank you. Thank you
Yeah,
for allowing me
thank you.
exam today.
Sorry, I didn't remind you while 1 minute left, but you
Okay.
finished already in 10 seconds. Okay. Now we can start the questions. Dr. Huda, please start.
Okay. What's the diagnosis for this patient?
Well, from because I just examined this gentleman who has history examination finding consistent with bilateral lower by basal fibrosis, as evidenced by inspiratory crackles that does not change with cough. Also, reduced chest expansion or,
Yes.
on the
Hello.
lower zone, as well as dullness in the lower parts in the lower by basal lung zone. All this put together, I think it has evidence of pulmonary by basal fibrosis, and also because of the joint abnormality in the hands, I'm suspecting this might be due to possibly rheumatoid arthritis.
Okay. What's the manifestation of the rheumatoid arthritis in the hand?
Okay, rheumatoid arthritis in the hand could include a Z deformity, can also have a botonine deformity, and also ulnar deviation of the metacarpophalangeal joints.
Okay. Another.
Okay, other hand sign could include no, is it deformity?
Okay.
Okay.
You can tell me what we will find in the pulmonary, what you will do investigation for this patient?
For this patient, I want to do a bedside. I want to check the bedside pulmonary for bedside spirometry to check for the pulmonary function test, and I'll expect I'll expect a restrictive pattern of pulmonary function test. Also, I also want to do a chest X-ray. I also want to do a chest X-ray as well as arterial blood gases to rule out any form of respiratory failure, though there is no clinical evidence of such in this man. Clinical other radiological investigation could do it could include an higher resolutional CT scan, where I will expect to see an honeycombing form of honeycombing change in the lungs. And if all these are not helping, a lung biopsy could be considered.
Sorry, doctor, what you said in the last, because I'm not
I
hearing
said a
well.
lung biopsy could be considered.
Okay.
Lung biopsy, yeah. She's considering lung biopsy at the end. Okay.
Okay. What's the cause of if the patient rheumatoid arthritis came with the shortness of breathing and cough, what the possibility?
Okay. Shortness of breath. Okay,
Yes.
could be people. Other possibilities could be a lung fibrosis like this patient had. Could also have a nodular a rheumatoid nodules in the lungs. Other possibility could be pleural effusion. Could be a possibility in rheumatoid arthritis with shortness of breath.
Yes. And drug also, like
Yes,
methotrexate.
methotrexate as well.
Okay. Thank you, Dr. Ayula. I finished the question.
Yeah, good question. Thank you, Dr. Huda and Dr. Ayula. Yeah, I can ask you one more question, Dr. Ayula. Okay. What do you think these crackles present?
What do I think?
The crackles you mentioned. What do you think the cause of it in this scenario?
The crackles, they are is the cause of it.
Yeah, the cause of crackles.
That the fibrosis in the lungs.
Okay. And what do you think that the drug-induced fibrosis could be the same basal or apical one?
It will be a basal fibrosis. Usually the basal
Perfect.
fibrosis.
Perfect. Okay, if this fibrosis established, what do you think the stage of fibrosis? Do you know what stage you know about fibrosis?
Yes, I know the stage of fibrosis, but I can't remember vividly now, honestly.
Okay, how you can diagnose the fibrosis?
Different fibrosis, the stages of fibrosis. Using imaging.
Yeah, what image you know?
That would be the Arizona CT scan.
Perfect. HRCT. Okay. And what stage you can find, you know,
Stage 4, the honeycomb stage.
the name. So
The-
the early stage, what's the name of the finding?
I can't remember now.
Ground glass.
Ground glass.
Ground glass. Okay.
Yeah. And what at the late stage, what we call it?
Honeycomb.
Honeycomb.
Honeycomb,
Yes.
honeycomb, that's the
Mhm.
mistake. Yeah.
Yeah. Perfect. Fair enough. I think now 6 minutes. Now the time for comment, Dr. Hoda, please. Well done, by the way, Dr. Yola. Comment, Dr.
Uh,
Hoda, please. Yes.
she's good, really very good. She do all the step of the examination, but she also examined the hand, and she the abnormality in the hand for the patient because he has rheumatoid arthritis. And only this is my comment, but she's very good.
Yes, I agree with you. The whole chest steps as examination she did, but she missed even one step for the hand or joint examination, Dr. Ayola, just to show the examiner that you find and you already discover this finding in the patient. So either to point by your hand about the deformity, or to inspect the hand or the joint itself. But you will not go, of course, to the detailed hand examination of the rheumatoid. Why? Because if you start to do, you will not finish this station. What I mean, look and feel and move. So the function and the fusion, but at least try to point to the deformity in his hand. For example, the Z shape. So you can show the examiner that there is Z-shaped thumb even by pointing to it. Okay.
Yeah.
You can inspect the joint for effusion once only. That's it. I don't think you can do the other steps like function, pick up the coin, or other joint examination unless you have time at the end. But if you start to do so, you will not find the time to examine the chest, which is the case today. So you have to finish the chest examination first if you have time, or you can add at the end. I would like to do complete examination of the hand or joint examination for rheumatoid arthritis. Okay.
Mhm.
Any test or any examination step you are about to miss and the time is already up or about to be at the end, you can mention before presenting the case. If I have time, I would like to do so. 1, 2, 3. Whatever you want to do. Okay. For example, in the examination of the abdomen station, if I have the time, I would like to examine the inguinal lymph node. I would like to do digital rectal examination, for example. Or if you miss, for example, the ballotment or auscultation for renal airway, anything you missed and you want to show the examiner that if I have the time, I will do, so you can say it. Okay, better than forgetting it at all. He will tell you, did you examine for this? Did you examine for that? You will feel like you miss a lot of things. But whenever you remember, please say it at the end. As well as I would like to do some blood test for this patient, pulse oximetry, ABG, and respiratory function test. After that, you can present. Okay, this sentence is it would impress the examiner that you are experienced with the chest cases. Okay. Apart from that, as a chest examination steps, you fulfill all of them. You start examining from the front of the chest, which is it's okay. You choose the one. You can choose to start from front. For me, as I said, it's better to start to examine the chest from the back. You will find a lot of findings from the back. from the front because of cardiac shadow, maybe it would be difficult. Anyway, sometimes you can hear it. So the crackles, it is the best to auscultate from the back, not from the front. Okay? The cardiac examination you did, the apex beat and pulmonary hypertension, which is positive here. I think you didn't miss all the things. The examination, also the examiner question, you did great. You mentioned most of the tests you have to do, but don't forget the investigation for the original disease. You didn't mention any test or any investigation for rheumatoid arthritis, which is the cause or the main underlying cause of this manifestation, right? So the case is about interstitial lung disease complicating rheumatoid arthritis. As Dr. Huda said, either due to the disease itself or the medication side effect. Okay?
Yeah.
Yeah, so the specific investigation you want to add here, you can put rheumatoid factor and anti-CCP, right? And all autoimmune screening you can add in this scenario. You might have features of mixed connective tissue disease. So it's not a matter of rheumatoid only. Any rheumatoid or any connective tissue disease, you might have the others either coming or it's already there, presenting or existing. You don't know what the patient is having as a symptoms. He might have the antibodies already in the blood, but the manifestation of disease either there as existing or still not existing yet. You got my point. So you have to screen for all the connective tissue and antibodies for any connective tissue disease, including rheumatoid arthritis, SLE, and systemic sclerosis, for example, dermatomyositis, antiphospholipid antibodies syndrome. By the way, it's profile, it's complete profile. Add to them at the end anti-ribonucleotide antibodies. Clear?
Yes.
These are the questions or the investigation for the underlying disease as a specific investigation. What about the bedside test here, Dr. Ayula?
You want to do a spirometry, pulmonary
Perfect.
function tests,
Perfect.
ECG,
And
ECG,
ABG. You mentioned ABG in the
ABG, yeah, ABG.
So always remember ABG in any chest scenario, as well as for any cardiac station. Remember the cardiac enzymes as a specific tests. Okay, these are the tips or the instruction to put to yourself while you are waiting for your turn to get in. Write in the station in the paper you have. I should remember the cardiac enzymes while I'm going to do the cardiac examination. I should do or put in my plan in the investigation nerve conduction study and EMG, for example, before going to the neurology case or nervous system case, to write in your paper before going to the chest examination scenario, ABG, spirometry or respiratory function test, and pulse oximetry. These things are very important to be mentioned while discussing with the examiner. And of course, it impressed the examiner because you are not saying something randomly, you are specifying what to do with the chest patient even before sending his routine labs. So I should do ABG, of course. I should do pulse oximetry to check for the oxygen saturation and spirometry to be done at the clinic. Okay, it's not present in every hospital. Back to the ABG. What the importance of ABG in such patient, Dr. Ayula?
You're looking out for respiratory failure and features of respiratory
Yes.
failure.
So in our patient, what do you think this patient would be presented with in the blood gas?
The oxygen, the partial pressure of oxygen will be low.
Perfect. Yeah. So
And
he might have hypoxia. Yeah. So it's what's called respiratory failure. Which type?
type 1 possibly.
Perfect. Type 1 respiratory failure. If the CO2 is high, what's called?
Type 2.
Yes. And if there is both, what we call it?
Mix.
Yes, mixed respiratory failure. Perfect. These are the bedside tests you have to mention in every chest station. ABG, pulse oximetry, spirometry, and you can add ECG and echo. What do you think the importance of echo in this scenario? Why you want to do echo?
Okay, because it can also have pericarditis, cause pericarditis.
Okay, as a sinusitis, you mean, okay?
Yeah. Mm.
But what's the important manifestation complicating any interstitial lung disease?
Okay, right ventricular hypertrophy.
pulmonary.
Perfect. Yeah,
Mm.
so to check for right side pressure, pulmonary pressure, and or blood right side pressure or pulmonary artery pressure, to rule out cor pulmonale as a complication for any interstitial lung disease. So the main aim for echo in this scenario to check for the right side and pulmonary artery pressure. Okay, the ECG as well, it can show you what possible ECG finding in this scenario.
Can show the P wave will be tall in the
Perfect. Yes, as cor
one.
pulmonale
Yeah,
as well.
V1. P pulmonally.
Yes, perfect.
bundle branch block also.
Okay, what? Sorry, Dr. Huda?
Right bundle branch block.
Perfect, yes. So either this or that.
Down.
So right bundle burst, right, or the P acute P or high P wave as cor pulmonale. Yes. Okay, these are the possible question for the ECG. Then the other investigation, yes, the image, as we mentioned earlier, HRCT, chest, to confirm the diagnosis as a complication. So the fibrosis might be there according to the stage, either ground glass appearance, early stage, or honeycombing appearance as late stage. Then the possible invasive test in this scenario would be Dr. Ayula.
Possible invasive test would be bronchoalveolar lavage.
Yeah, bronchoscopy for bronchoalveolar lavage.
Mm.
Yeah, I think this is the possible invasive in this scenario. Add to them, you might do joint aspiration, but it's not the case, so it's for the original disease. Okay, if there is cor pulmonale, what invasive test you can offer to this patient?
Pulmonary right catheterization of the
Perfect.
catheterization.
Yes, right side heart catheterization. Okay, and then the management plan, as you mentioned, start always with multidisciplinary team. I like when Dr. Huda start the management plan by calling multidisciplinary team for the previous scenario, as well as in this scenario we will call for multidisciplinary. So the rheumatologist, even clinical pharmacist, you might call for the drug induced. If there is possibility, it could be related to the methotrexate, for example, or medication. And of course, the pulmonology, the cardiologist, respiratory therapist, as well as the occupational and physiotherapist. These are the multidisciplinary team as a approach. Then the pharmacological option. Dr. Ayula, question. What are the pharmacological options for our case particularly?
Okay. First is if you think suspecting a drug induce, is to withdraw the medication that might be responsible for this. And then there are some antifibrotic agent that can be used. Well, we start with steroid, depending on the stage. You want to start with steroid.
Yes, with steroid at the early stage,
Steroid,
yes.
yes. And then antifibrotic agents.
The rule for antifibrotic in the idiopathic pulmonary fibrosis, right?
Yes.
Yes, yes.
So
Yes.
no role here. Okay, what are the name or what is give me example of anti-fibrotic, not in this scenario, but can you remember the name?
Um, Phenidone. I can't remember very well. I can't.
Birfenidone
Yeah,
Phenidone.
yeah.
and nintedanib. Okay, The last question, Dr. Ayula, for the chest. I forget. Okay, I think, yeah, yes, the definite treatment for this patient is if it is a honeycombing and advanced stage lung fibrosis. What is the definite treatment?
Lung transplant.
Yes, exactly. Always remember it as the last step, either this scenario or the previous scenario. So I can give option of surgical treatment in the form of lung transplant, either single or bilateral.
Mhm.
Okay. For the briefest scenario, even you can offer the pancreatic transplant. Well done, Dr. Ayula and Dr. Huda. Really, it was amazing performance by both of you, particularly Dr. Huda because she wasn't prepared. But as usual, Dr. Ayula, she was impressive. Any question from Dr. Huda or
Yes.
Dr. Ayula? Yeah. Any question?
Thank you, Doctor.
Thank you to Dr. Huda.
Thank
Dr.
you, Dr.
Ayula,
Bazin.
most welcome. Any question?
No.
Anyone with a question? Any message in the chat box? Yeah, I wrote these in the chat box. Always remember them. Try to train how to present. Possibly you might forget these things. I wrote it down. Okay, this stuff, please remember them while doing examination or while presenting. So the thing mostly forgotten by candidate, the surrounding, either during examination or even during presentation. Sometimes you pick up it. Oh my God, I saw this, the oxygen cylinder. But when you present, you will forget to say, I noticed oxygen cylinder, as well as the wheelchair, as well as the stick, walking stick in the neurologist station, or even some medication, the bottle, or for cough or sputum collection. So remember always to start with the surrounding. I examined this gentleman. I noticed there is oxygen cylinder before mentioning anything. Why? Because you will forget it. And the most important, while examining, point to the thing you found. For example, oxygen cylinder. When you saw it, you can point to it. Why? Because you might forget to mention it. But at least you show the examiner that I point to it, that I saw it. Okay. This is the clever way how to show the examiner, even you are forgetting presenting them. But of course, the full mark would be for the one present mentioning these surrounding. Back to the things. So the surrounding, the trachea, don't forget to do it. And if you have suspected COPD patient, you have to do the tracheal tug. If you notice the trachea is short, you have to do the tracheal tug. Cardiac examination, of course, the apex, particularly with coarse crackles patient or a patient with wet cough. The lymph node examination while patient is sitting after finishing examining the trachea, the same time examine the lymph node cervical and supraclavicular. The ABG, you have to mention it while saying I am going to do some specific bedside test, not specific bedside test, including the ABG and pulse oximetry. So you can add to the ABG pulse oximetry. The last thing, whenever you have COPD patient with bronchiectasis, recurrent chest infection, even heart failure patient, splenectomy patient, please remember the vaccination. Okay? Please add this to your tips. It's very important. Dr. Sarah Bashir, I should start examination from the front or from the back? Again, Dr. Sarah, my favorite approach, the hand examination. Of course, you stand at the end of the bed after finishing the surrounding. The cuff and expansion grossly from the end of the bed at the end of the bed. The leg examination for tibial edema or pedal edema. Then I will examine the hand, peripheral sign, the tremors, clubbing, the pulse, The face, I ask the patient to pull his eyelid down for pallor or jaundice, up or down for pallor and jaundice. Then the face for the mouth, sorry, for central cyanosis. Then the gum, if there is scar, suspected transplant, gum hypertrophy is important while opening his mouth. Dental caries, dental hygiene. Then the neck now for trachea. Patient is sitting, so I will check for trachea. Is it central or no? And I will examine for the lymph node while patient is sitting, the cervical, supraclavicular. Now I will examine the front for cardiac examination. I will ask the patient to lie down, semi-sitting, not lie down, semi-sitting, and I will examine the apex, pulmonary hypertension, parasternal heave, loud B2, and the raised GVP. You have any tummy pain? No. I will ask him, sorry, I will examine for the raised GVP. Now the time to set the patient again up and examine the whole steps of chest examination: inspection, palpation, percussion, auscultation. Almost 99% of your steps done whenever you finish the back examination as chest examination steps. If you have few seconds, start to do the same steps of chest examination from the front: inspection, palpation, percussion, auscultation. Be sure you examine the chest's whole side for any scar until the axilla. Some patient they have a scar under the axilla. If you miss it, you miss the case. For lobectomy or for lateral thoracotomy scar, for bollectomy or lobectomy. But for pneumonectomy, it's big scar. It would be parallel to the chest cage or the chest wall or the last strip down. Okay, costal margin, parallel to the costal margin. But for the lobectomy scar, it could be small. You might miss it if you didn't do good inspection and exposure under the axilla. Is it clear now, Dr. Sarah? Okay, I hope it's clear for all. Any question with any or any suggestion, any missed point, sorry.
Dr. Basim,
Okay,
I have one question, please.
sure.
When cough disappear with crackle, when there is crackle,
Mhm.
not disappear or disappear with coughing, what does this mean?
Disappear or this doesn't disappear?
Yes,
Okay, I will tell you both.
both
Both,
condition.
okay.
Yes, yes.
If you have crackles, inspiratory crackles, and you ask the patient to cough, if it disappears means this is secretions. Okay, mostly it would be bronchiectasis or pneumonia. Okay, or pulmonary edema, for example. Whenever there is crackles which disappear, means it is secretion. And the other type, if you have crackles and doesn't disappear or doesn't change with cough, means it is fibrosis. That's
Okay,
why
thank you.
whenever you have crackles in paces, ask the patient to cough. Okay?
Okay, thank you very much.
By the way, most welcome. By the way, the crackles of the bronchiectasis will be coarse crackles. But for the fibrosis, it would be fine and very difficult to auscultate it. You have to train how to pick up the inspiratory crackles of interstitial lung disease or fibrosis. It's like something very minute sound, like whenever you have plastic bag and you are putting inside your fist, this is mostly the sound. Okay, you got it? So try to put a plastic bag inside your hand fist and squeeze your hand. You might hear some sounds. It's almost resemble the sound for the crackles of inspiratory, crackles of fibrosis. But you have to hear it by yourself. Okay.
Okay.
Any other question? Any question? Okay. Have a nice weekend. Good luck and good night, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh.